Hello, my name is Katrina. I'm an FY2 on my psychiatry rotation, working for the mental health liaison team in hospital. I decided to make a presentation about delirium for medical students and new doctors. So the rationale behind this was I found in medical school we weren't really taught much about the underlying mechanisms of delirium. We were mainly taught about what the common causes are and then how to manage it. But because of that, I felt translating that then into practice was difficult because I found it hard to be able to recognize what delirium was, and then in order to treat it properly, and then assessing capacity I found quite difficult as well. Not really understanding how it all fit together. So the goals of this presentation is to make it a bit less nebulous and wishy-washy in terms of a concept, making it easier to understand and apply principles in practice and link it to mental capacity as well. So I was thinking about how to best organize this presentation. So I think I'm going to start with focusing on two concepts that I felt would have made delirium easier to understand. And one just in general relates to different levels of brain function. So obviously we learned in medical school that different areas of the brain are involved and responsible in different processes and function. And that certain functions are linked to certain brain areas. And we call this localization of function. And localization of function most reliably occurs for sensory processing. So anything that's heavily involved in processing any information relating to the five senses, and then subsequently motor output as well. So anything to do with those things tend to be specifically localized to brain areas. So for example, motor function is found on the border of the frontal and parietal lobe. It involves premotor areas, supplementary motor areas, primary motor cortex. And that's all highly evolutionarily conserved. It sits in one place and it's solely responsible for the motor planning and motor output of the body, obviously including the basal ganglia and things like that. But for simplicity's sake, I'm talking mainly about the neocortex. So these tend to sit in specific brain areas. The same is true for audition in the auditory cortex, whether that's primary processing of auditory information or supplementary processing as well. And I guess it's worth noting that although we have these primary areas, for example, the occipital for primary visual processing, the more complex processing of information will then move to different areas of the brain. So with vision, the more complex the processing of what you're seeing is, the more it will move to different areas of the brain. So it will move more into the parietal and the temporal lobes, the more complex that processing gets. So the reason I'm going on about this is essentially to say that more higher order functions, the processing that's more complex than just the basic processing and output of information will require multiple brain areas to be active at one point in time to create what we call higher order functions or more complex processing. So like I just mentioned about audition, the primary and supplementary auditory cortices will process what is being heard, but in order to understand the meaning of words and the context in which it's spoken, in order to have an appropriate understanding and response, will require other brain areas to be active at once. So if you want to understand a meaning of the word, you'll have to access memories of that word, which is more in the hippocampus, amygdala, and frontal areas. And then you'll have, visual memory, or visual neuronal networks associated with that, let's say, word that's being processed. That becomes active. And quite quickly, you see all sorts of different brain areas and motor areas, interestingly, active all at once to understand that piece of information in context. So with higher order functions, we're talking about reasoning, understanding, decision making. These will require multiple areas to be active together in order to facilitate that higher order function. And one way this can occur is through something called brainwave synchronization. So if you've ever seen an EEG, where you put electrodes all over the head, each electrode will pick up a specific population of neurons or neuronal tissue, and it will give you a waveform, very similar to what you have when you record an ECG, but it's specific to brain activity. So one way to understand this is, because of the different areas of the brain that are responsible for different processes, you will have brainwave synchronization between multiple brain areas when a higher order cognitive function is taking place. And the reason I'm explaining this is because, just to show you how fragile this process is, and in order to engage in a higher order cognitive function, you need to have multiple things that are working together properly at a specific point in time to give you a certain result. And obviously, if there's some sort of a lag, or a certain area of the brain is, for example, inflamed or not working properly, there'll be a quick breakdown in this higher order function, because all of the moving parts are not working together. Just like if one component of a car isn't working properly, the car is not going to work. So you won't get that complex function as a result. And this is just a reference if you're interested. The second concept I wanted to explain is that of physiological reserve. So I actually didn't learn about this on medical school. I learned more about this on my ICU rotation when we were deciding which patients were suitable for ICU intervention or not. And it's basically this concept, or it's rather a measure of an organ's ability to maintain function despite a stressor, or its ability to return to homeostasis, or return to its normal function following a stressor. So, for example, in heart failure, we know that the cardiac myocytes themselves have changed. So, for example, like the mitochondria works differently, proteostatic mechanisms within the cell don't work as well. And so you get a cell that functions suboptimally, and its ability to repair itself as well doesn't work properly. So when it undergoes a stressor, its normal function is compromised to a degree, and its repair mechanisms are compromised as well. So then that translates to the tissue level and then the organ level. And what you end up getting is an organ that doesn't fulfill its function, essentially. And this is just to say that as we age, as you all know, you acquire DNA damage, and then obviously that translates to RNA and protein and then function within the cell. And as you accumulate more damage, that just translates into cells, tissues, organs working suboptimally due to normal aging. If you add on comorbidities such as diabetes, hypertension, everything you can get with these elderly, frail patients in hospital. You get that superimposition of stress, chronic stress, and chronic dysfunction of cellular mechanisms. And that just translates to this person not being able to withstand a great amount of stress. And the reason I'm explaining this is this also obviously applies to neurons and brain tissue. So over time, the neurons and the brain tissue isn't going to work as well, especially when you add comorbidities on top. And therefore, the most fragile functions of the brain, which are the higher order functions, aren't going to work as well either. And especially then when you add on an acute stressor, that will be even further compromised. Again, just another reference. So quickly, just now putting that all aside, reminding ourselves of some terms. I'm sure you all know this, but I'm just going to quickly go over it. Just reminding you that delirium is a rapid onset and normally, quote unquote, reversible deterioration in brain function over hours to days. Whereas dementia is slow or stepwise and irreversible deterioration in brain function over months to years. And that's kind of how we generally tell cognitive decline, especially in the elderly, apart, because dementia tends to be slow and progressive onset, and delirium is rapid and potentially reversible, normally reversible to some extent. And this is the classic chart that you normally see in the textbooks. You can press pause if you want to look at it. And so just putting it all together, delirium in the elderly. So we talked about how aging can cause a decline in cognitive function, especially when you add comorbidities on top. And that decreases a patient's general physiological reserve, but then that also means the brain's physiological reserve is reduced as well. And depending on the extent of that reduction of physiological reserve, that creates a vulnerability to any sort of acute stressors that patient might experience. And for example, if the patient goes into urosepsis, a classic, those homeostatic mechanisms in the neurons, that resilience of those neurons are impaired. So I guess you can kind of see delirium as a decompensation of higher order functions in the brain due to an acute stressor on a background of reduced physiological reserve. So changes in the neuronal environment due to infection, increased cortisol, sympathetic activity, can create kind of a chaotic environment for those neurons, change the way in which they transmit information, and it can make normal neuronal firing more difficult. And then as a result of that, you get a loss or a desynchronization then of the different brain functions required to maintain a higher order function. And this will then result in difficulty in understanding information. So let's say a patient has urosepsis. Those inflammatory mediators have entered into the brain. Again, that cortisol is in the brain or affecting the brain as well. The sympathetic nervous system affecting the brain as well. So you've really created an environment that's different from that patient's baseline. And because those neurons are so fragile and they're not really resilient, they aren't functioning or firing properly. So the higher order functions then don't work adequately. And let's say you have the patient's able to hear and they're able to maybe process preliminarily that sensory, let's say auditory information, but then the meaning required to understand that information is impaired because you can't have those brain areas all working together. So that's why their understanding can be impaired. The retention can be impaired because if you think about sleep, that's a highly synchronized and stepwise process that occurs in the brain. And if that's not able to happen, you can't really consolidate information into long-term memory. And with short-term memory as well, retention, that requires processing of that information and spreading it out into different brain areas, which then can't occur. Weighing up information then can't occur because you haven't understood or retained the information in order to manipulate it in your brain. And then obviously communicating a decision based on all of those three things can't happen in a meaningful way because you don't have multi-area or multimodal communication in a meaningful way. So the rest of the presentation is basically identification and management of delirium, which you've learned in medical school. So I'm not going to spend as much time on it, but I will just go through it. The way I remember the causes of delirium is through a mnemonic. So it's literally delirium. So drugs that can cause delirium are any drugs that alter neurotransmission in the brain. Since these are dirty drugs and act on all areas of the brain and within the body, unfortunately, you can't really target that medication to a specific area in and of itself, or we don't yet have the more specific drugs to do this. So for example, if a patient has stress incontinence or like an irritable bladder, we give them sulfenazine, for example, an anticholinergic, but that can also cause cognitive impairment and delirium. Opioids as well, benzos, lorazepam, diazepam, are Z drugs, so the sleeping drugs, zolpiclone, zolpidem, things like that. Emotion, so stress. So like we've said before, stress can increase sympathetic tone, sympathetic nervous system, increase cortisol. That can alter the brain's environment in which those neurons are working, and that can cause delirium as well as depression. All of the neurobiological mechanisms of depression can alter brain function as well because of the reduced physiological reserve. As well, changes of environment, because when we change environment and we are in a new place, the brain, that puts a heavy cognitive load on the brain in terms of processing information. So that can overload the brain and put someone into delirium who has very low physiological reserve. Low oxygen, I think that one's a bit obvious. So any chest infections, COVID, heart failure, aortic stenosis, strokes, PEs. Infection, this is probably the most common thing apart from drugs. So typically chest and urine infections, especially when they go into sepsis, and that starts to affect the brain. Retention, so I've asked around as to how urinary and fecal retention can cause delirium. The only kind of answer I've gotten, and the way I understand it, is that when you're in retention, the brain's the nerves are constantly signaling information to the brain, and that increase in sympathetic, parasympathetic tone can kind of disrupt the brain's processing of information potentially, and that can put them into delirium as well. Ictal states, that's self-explanatory, I think, and undernutrition. Obviously, nerve cells, just like any other cells in the body, require adequate vitamins and minerals to maintain their biochemical processes, and that's the same with metabolic function. So we just looked at causes for delirium, assessment of delirium. So we often in hospital use the AMT4, So we ask the patient if they know where they are, what year it is, their age and date of birth. That's the MD Calc if you're interested. And it's just a short, quick assessment to see whether they know the basics. And normally in the elderly, if they fail this assessment, I think further information needs to be gathered. So that might be a collateral history from relatives and care staff. So the daughter, for example, of an elderly patient might say, oh, she was fine a few days ago, and then all of a sudden she just started becoming more aggressive, more agitated, not knowing where she was, and becoming incontinent, things like that. And if you're on the ward and you're assessing for delirium, you might ask the nurses or the care staff to start recording the patient's behaviors and then having a look at their input and output charts to see if they're eating adequately, whether they're opening their bowels, whether they're in urinary retention, just to optimize causes and treatments. The use of antipsychotics or benzos, so you can look on EPMA as well, seeing whether the staff had to administer, let's say, any lorazepam during the night, or what's been going on, just to give you like a fuller picture of whether this patient is or isn't in delirium and the extent of it. And then obviously the reason for admission. So the patient had a fall, very confused, incontinent. So you might certainly then be looking to see whether they're in delirium and what the cause for that might be. And then obviously doing the confusion screen like we talked about, CT brain, chest x-ray, MSU swabs, all the usual stuff. Management strategies. So management of delirium is treat the underlying cause, obviously, to see whether we can reverse the delirium. And then obviously the supportive care aspect as well. That's really important. So treating the underlying cause, again, I'm going to give you a mnemonic. It's just what it says on the tin. Look for what might be causing it and treat it, essentially. And then obviously there are some other considerations to make. So my mnemonic is Ohio Meds. So obviously you want to try and orient this person back, but that's part of supportive care, which we will discuss. Make sure they're adequately hydrated. Any infection screen is done, and that's then managed appropriately. Any oxygen if it's needed, correct any metabolic and electrolyte abnormalities. Review of medication. So again, if they're on anything that could be causing delirium. And on the flip side, for example, pain, if they're on too many opioids, that can cause delirium. But also, if they're being inadequately pain controlled, that can also cause delirium because of what we described about the sympathetic nervous system and stress and cortisol and things like that. And then supportive community care as well. So this we'll talk about a bit later. So thinking about advanced care planning, if necessary, palliation hospice, and involving the community team. So supportive care. Often in hospital, I think this is missed, but it's the second half and it's a big aspect of the care of someone in delirium. I understand why it happens. The hospitals are really stretched. There's not enough nursing staff. There's not enough support for all these patients. So this aspect is often neglected, but it can prolong a patient's stay. It can increase their symptoms of delirium, which might end up getting them medicated with antipsychotics and benzodiazepines. It can cause, again, prolonged stays and prolonged delirium episodes as well. But these are definitely things to consider. So again, made a mnemonic because I'm full of them. Reorientation strategies, so that would be clocks, calendar, just to give their brain a frame of reference anchor them into reality. So give them a clock, tell them what time it is. If they have a window, they can then look to see if there's light outside to give them that congruency. And then a calendar to see what day of the week it is, again, anchoring them back into reality. Another important thing is getting them out of bed when it's not bedtime. So they have the clock, they have the light outside and the calendar. If they're out of bed, they know it's daytime. And if they're moving around throughout the ward, their body knows that it's day and they're not meant to be sleeping. They're not, dissociating in bed, being more confused. Regular meal times, again, it's trying to create that, it's trying to fix that circadian rhythm in the body, and obviously feeding them and building their strength and giving their cells the nutrition they need to function properly. The environment, obviously, if there's a lot of noise and stimuli, that puts more cognitive processing load on the brain, and it just might not help the situation. So it might be helpful to, as much as you can, simulate a home environment to reduce that cognitive load on their brain. But obviously, if they're sitting in a bay with other patients, I don't know how realistic that is. A quick discharge in that case as well is ideal, but I don't know how often that happens. And then the opposite of overstimulation is understimulation. So if you're sitting with them, you're engaging them in conversation, you're forcing their brain to engage in meaningful function, to push through that aberrant processing in a meaningful way. Pain management, like we just discussed, make sure it's adequate, and consider maybe things that won't make their delirium worse. So if they have a NOF, for example, giving them a nerve block rather than dosing them with too many opioids orally. And then sleep management, again, this is part of the reorientation, circadian rhythms. You can give them earplugs, eye masks, and consider melatonin and trazodone to make them sleep. Because obviously if they're in a bay with other patients screaming and the lights are on, I don't know how much chance they have of reorienting themselves and fixing their circadian rhythms. So sorry about this. I think I was meant to animate this so that it would be one point at a time. But anyway, medical management of delirium. Without even looking at the text, basically we should focus on supportive care and treating the underlying cause. But of course, as we know, and we've seen in hospital, patients in delirium can sometimes become aggressive, agitated, psychotic, especially when they're in hyperactive delirium. So sometimes there is a need to give them something. So the gold standard for these symptoms within the context of delirium is haloperidol. Obviously, that's assuming they have a normal ECG and don't have any contraindications. Lorazepam isn't ideal because it's a benzo and it can prolong or worsen their delirium. But sometimes when haloperidol is contraindicated, and if their aggression, agitation is really severe, they might require tranquilization with lorazepam. But again, always remembering that these can worsen the delirium as well. So you must use the lowest effective dose for the shortest period of time. And if both aren't working or they're contraindicated, you can always ask about other antipsychotics like risperidone and olanzapine. You can get a psych liaison consult with an old age psychiatrist as well. Right, so one of the last things I wanted to talk about, which I think is really important in considering the bigger picture of their care, is outcomes of delirium. So I didn't know this, but when I was reading about delirium on Up to Date, I found that the 6-month mortality, delirium has a 6-month mortality of 14 to 22% from one episode of delirium, and that's an independent risk factor for death. So a patient who's come into hospital with one episode of delirium and that's never had one before has a chance of dying of 14 to 22% within 6 months. And I think that's huge. That's absolutely huge. And that kind of gives you an idea of their baseline and their physiological reserve. Like, this person cannot handle adequate engagement of their brain in the real world because it's becoming so fragile. And we had a patient actually who, she had a stroke and then went on throughout the year to have 11 admissions of delirium into hospital. So if you calculate that, her mortality, 6-month mortality is 100%, basically. I don't really know how she lasted to the end of the year. Obviously, there's a lot more behind these statistics. But we just had to tell the family that this patient was probably not going to live into the next year. And we talked about advanced care planning, deciding that this was the ceiling of her care, talked about stopping readmissions into hospital and things like that. So with these stats in mind, you can make better decisions for patients and for their long-term care when you look at the bigger picture, essentially. Another thing to consider is delirium. Depending on the physiological reserve of the person's brain, delirium may persist up to 12 months after an episode of delirium, or it might never resolve. It might be their new baseline, and that's called persistent cognitive dysfunction after delirium. And this is what we talked about. A reduction from baseline can frequently occur, like we've mentioned, because of the reduction in physiological reserve, because the repair mechanisms just aren't adequate, and they're not there. So once a patient develops delirium, not only do they have the episode, but they don't return to baseline, essentially, because they don't have that physiological buffer. So again, with this patient we saw that I just mentioned, her baseline after each episode of delirium, according to family, was declining and declining and declining. And right before admission, it was so bad that she couldn't function anymore. And so we thought she probably had an underlying dementia because of all of the insults that had happened to the brain within the year. And then this brings us on to the last point. When do we refer to LAMS after an episode of delirium? So this person's been in delirium, let's say all their bloods are normal, everything's been treated, adequate intake output, they're ready for discharge, but the delirium hasn't improved, or they're not orientated adequately to be discharged and live at their previous baseline. So when do we do a LAMS referral? So just generally speaking, if the patient is displaying symptoms of cognitive impairment, whether that's during the admission without an underlying cause or after everything's been resolved, and this will then subsequently affect their life and ADLs, it's worth considering. And yeah, we've just talked about that. And also, a LAMS referral can be made if there's a patient with known dementia, but who've now have developed symptoms that are becoming unmanageable. This I've just taken from a LAMS referral itself. So these are the symptoms to look out for when you're making a LAMS referral or considering a LAMS referral. And what LAMS will require? Obviously, for delirium to be excluded or concluded, and there's nothing really else to treat, but their symptoms are persisting. Yep, and that's what we've discussed. Confusion bloods are normal and their comorbids are optimized. They might also require a screening tool to be completed as a more objective measure than your subjective opinion of the patient. And this is a question I have struggled with and I've heard quite a lot. And it's, how long do I wait to refer a patient to LAMS after a delirium episode? And unfortunately, the answer to that question is it will depend on the physiological reserve of that patient's brain, which is different for every patient. And also given that delirium takes weeks to months and up to a year to resolve, it can be really hard to make that diagnosis. But I guess as a rule of thumb, if you've treated everything, you've optimized everything in that patient's care, you waited a little bit, but the patient is still not improving, I think then it's very fair to refer to LAMS, and they can then decide whether they need a longer period of recovery or whether they're happy to see them. So that's not really a decision you have to make. I think your role is you've done everything reasonably possible to optimize this patient's cognitive function, and that's failed to return them back to an adequate baseline. Anyway, so that's the end of my presentation. Thank you very much. Feedback would really be appreciated for my portfolio and just to help me improve for future teaching as well. Thank you very much.